This call is now being recorded.
Invited us to this meeting, Dr. Ahmed Rafat and the colleagues at the Shebin ElKom Teaching Hospital. So, Dr. Ahmed, you are free.
Thank you, good evening all. You are welcome in our nephrology scientific meeting, Shebin ElKom Teaching Hospital. Welcome, Dr. Rasha, Professor Dr. Georgina. We are today to introduce our case postpartum nephrology syndrome with Dr. ElKom. Dr. ElKom.
Thanks, Dr. Ahmed. Thanks, Dr. Rasha. Thanks, Professor Georgina. It's a great honor to us to join our meeting. Let's start our case.
Yeah, please.
Our case today is about a female patient, 19 years old, with free post-medical history, prime gravida, present at 35-week gestation with elevated blood pressure and pitting edema, started 3 weeks ago. The pregnancy was terminated at 35-week gestation with live-born baby, and the patient referred to the nephrology department. By examination, blood pressure was 190/100, and there was bilateral lower limb edema. By investigations, serum creatinine was 1.3, urea 41, hemoglobin was 10.8, TLC 7.5, platelet 277, serum albumin was 1.7, urine analysis there was RBCs from 8 to 9 and the protein plus 3. Albumin creatinine ratio in urine was 7,384 milligram per gram. 24-hour urinary protein was 20,000 milligram per day. Total bilirubin, direct bilirubin, ST-LT was normal. INR was 1.2, C3 and C4 was normal. ANA was negative, and cholesterol level, triglycerides were elevated. Cholesterol level was 392, and triglycerides was 710. HDL was 26, and LDL was 224, and virology was negative. Renal ultrasound show both kidneys average size with good corticomedullary differentiation, no stones or bad pressure, minimal intraperitoneal free flow.
And
the problem.
May I ask, the laboratory investigations you presented were just before termination of pregnancy or after delivery?
After termination.
Okay.
The problem was hypertensive, new onset hypertension, and nephrotic syndrome, proteinuria, hypoalbuminemia, and hyperlipidemia. So the question now, is it preeclampsia only or other GN? By definition, preeclampsia is a pregnancy-specific hypertensive disorder occur after 20-week gestation with new onset hypertension over 140/90, or proteinuria over 300 milligram per day, or evidence of end-organ dysfunction without proteinuria. Differential diagnosis of proteinuria in this case, it may be related to pregnancy or other kidney disease. Pregnancy-specific causes may be preeclampsia, HELLP syndrome, or acute fatty liver of pregnancy, or TMA. Pre-existing kidney disease may be lupus nephritis, diabetic nephropathy that worsens at second or third trimester, or maybe primary GN as focal segmental glomerulosclerosis, membranous GN, or minimal change disease. Biopsy or not? What's your opinion about this case? To do biopsy or not to do? Actually, we do biopsy. Why? As it nephrotic syndrome after pregnancy. The biopsy shows that light microscopy examination revealed poor fixing renal cortical tissue and can't properly assess. Immunohistochemistry show no deposition of IgG, IgA, nor C3 antibodies, and antibodies was negative. The electron microscopy examination show a single glomeruli revealed segmental glomerulosclerosis, glomerular basement membrane wrinkling, and collapsing segmental endothelial injury, and glomerular basement membrane double contouring. Diffuse effacement of podocyte food process was present. No electron dense deposits detected. So the diagnosis was a picture of TMA. In this paper, published in the Journal of the American Society of Nephrology,
excuse me. Just, I'm sorry. Can you tell again what was the diagnosis? Because there was a gap and I did not hear what you said.
Picture of thrombotic microangiopathy.
So would you please share the pathological picture again, Dr. Wian?
But do you have light microscopy too?
Can't be assessed.
So would you share the report once again? So here, Professor Pickley, as you can see in the light microscopy, it could not be evaluated because the renal cortical tissue was poorly fixed. But the immunohistochemistry revealed deposits, no abnormalities. Antipolar antibody was negative.
Yeah.
And
Yeah,
the
but
electron
sorry, I got these, but I think that making a diagnosis of chronic thrombotic microangiopathy on one glomerulus only,
yeah.
it's, I mean, I fully understand the difficulties, but one glomerulus only is like when swallow does not make spring. It's too little, and it's the diagnosis of chronic thrombotic microangiopathy should be a mix of light and electron and immunohistochemistry. So I'm sure that your pathologist did a fantastic work, but formally you cannot diagnose it by electron microscopy on one glomerulus. Also,
I think
the effacement of podocytes present is a sign that we find in all forms of severe nephrotic syndrome, and endothelial injury is also a feature of severe preeclampsia, while double contouring is not. But on one glomerulus only is very difficult to give a definitive diagnosis. So this is what I was just asking, but
yeah.
I don't want to doubt on what has been seen, but without light mic on one glomerulus only is not a formally acceptable diagnosis. It can be a strong suggestion.
If we're back to the clinical presentation of the case, they had a 19-year-old female patient. I think this is her first pregnancy, if I'm right, if it's correct. And the patient presented as 35-week gestation, severe hypertension, and proteinuria. Is this summary? So a patient presents at 35-week gestation with severe hypertension and the nephrotic range of proteinuria, a full-blown picture of nephrotic syndrome. This is a summary of the case. Is it correct?
Yes.
Yes.
So at this point, what would be the differential diagnosis of this case? Professor Quickly, I'm sure that you have seen maybe thousands of such cases. So what do you consider the difference?
So severe. The point is the severity of this case. And what I did not get, because the audio is not always perfect, is the delay between the presentation and the biopsy, between delivery and the biopsy. How many days after delivery was the biopsy performed?
2 to
5
3
days.
days.
I think this is one of the quickest biopsies taken after delivery. It's only 2 to 3 days after delivery.
Okay, but why? I mean, one of the things is I'm sure that you cannot refer to the nephrology department all cases with severe proteinuria and hypertension in pregnancy. So there must have been something that clinically have made you suspect that this was not a severe form of preeclampsia. What was why was the patient referred to you instead of saying, let's wait a few days and see what happens?
Yeah, have you got the question? It means if the case is admitted in the obstetric department, they almost will diagnose the patient with preeclampsia. So why they refer the case to you as nephrologist to manage it?
Because of severe proteinuria and hypertension.
Yeah, but severe by themselves, severe proteinuria and hypertension. I mean, you see patients with preeclampsia with 20 grams of proteinuria, not every day, not very often, but the severity of proteinuria and the severity of hypertension are not by themselves a reason for suspecting another kidney disease. So I was just curious to know if it was only the severity of a case or if it was because there was something else that did not fit into the picture. The baby, was the baby normal for gestational age or was the baby small for gestational age?
Was normal for gestational age.
Okay, so this could be correctly, this could be a clue for suspecting that the severe proteinuria and hypertension are not the result of a classic severe preeclampsia, even if this holds true more for early preeclampsia than for late preeclampsia.
Yeah, and this is exactly the point we want to learn. According to your expertise, to what extent nephrotics and a presentation of nephrotic syndrome is common in patients with preeclampsia?
Well, it depends a lot on how these patients were followed up previously, because in some cases, the disaster occurs and even spontaneous delivery occurs early. But if a patient has not been followed up, you do not know if this very heavy proteinuria developed over 2 months or 2 weeks. It's not immediate, of course, because otherwise the level of serum albumin would be normal. And indeed, I fully agree with you that at least this case raises a suspicion of a disease other than preeclampsia because the baby had a normal growth that suggests that that placenta was functioning decently or well until recently, and the albumin was low, much lower than you would expect in pregnancy, but suggests that the proteinuria is not a matter of a few days. So I fully agree with you that such a picture may be suggestive of another disease. Conversely, personally, I would have probably, unless, I mean, you saw the patient, so you have for surely seen small things or details that could be different, but I would have waited probably at least 1 week to see what happens, because very heavy proteinuria takes often few days up to several weeks to reduce, especially if the patient is very edematous. So this is one of my questions. Was the patient very edematous, and how much weight did she lose immediately after pregnancy? We usually wait a little bit more before a kidney biopsy, because the component that is related to pregnancy usually improves at a speed that is dependent upon the severity of the kidney damage. So you can have 3 grams of proteinuria going to 1 in days, but 10 grams of proteinuria you do not expect to go down very, very fast. So in summary, I fully agree with you that the suspicion of a non-preeclampsia is absolutely reasonable. I think that this biopsy can suggest but cannot state anything, because it's one glomerulus without light microscopy is not enough to make a diagnosis.
Yeah. Professor Broccoli, do you frequently see nephrotic syndrome in patients with preeclampsia?
Well, if you call, I mean, it's not a real nephrotic syndrome, but if the question is, do we frequently see high blood pressure, high level proteinuria, low albumin levels, but persist for days, weeks after delivery, and then without any treatment disappear? The answer is yes. It's one of the pictures of severe preeclampsia, especially when serum creatinine increases. So the picture does not rule out preeclampsia. What suggests that there may be something more is more the fact that the baby had a normal growth. So normal growth is usually associated with kidney diseases more than preeclampsia. However, we do not know if a baby was, for example, large for gestational age at 30 weeks and became normal for gestational age at 35 weeks. I mean, it's the cynetic that counts. And it's more than all is what happened later that makes the difference. So I'm very curious to know the rest of the story.
Do we have like serial follow-up for the patient's ultrasound, the baby's ultrasound, Dr. Rian?
No.
So is the first time the patient has been evaluated at 35 gestational week?
Yes.
Yeah, this is the problem with this. Is I fully understand. It happens also in high income countries like France, that patients are the problems. They start developing edema, being not that well, but the things are overlooked. So what happens next? I'm very curious to know the rest of the clinical story.
Thank you.
So Dr. Ann, please continue the case.
Our case follow-up after 10 days, serum creatinine was 0.7, serum albumin 4.5, and urine analysis no proteinuria. The patient completely resolved without treatment.
Okay.
In all days.
I think this makes the diagnosis. It was a severe preeclampsia. You have also to consider that three things. First of all, the biopsy was unluckily, because sometimes it happens, it's not is not enough. The electron microscopy is compatible with severe preeclampsia because there is endothelial damage. This double contour, I'm not a pathologist, but double contour, especially if the sample is not fantastic, like it happened in this case, when in the preparation for electron microscopy, the basement membranes are very fragile, so you can get the impression of double contours that are more an artifact. If you have englomeruli, you see it. If you by chance have only one, you cannot conclude, but double contour maybe is one of a possible relatively common artifacts of electron microscopy, while the endothelial damage is actually highly compatible with preeclampsia. You have also to consider that our experience on biopsy in preeclampsia is very limited because we have just very old series, and recently the only cases that are described in the last, let's say, 30 years, except for a very controversial small series from Norway or Sweden, in which they even made kidney biopsies in normal young women in the end of pregnancy, and found some cases, some features of endotheliosis even in normal pregnancies. We know very little of a kidney biopsy of pregnancy, of preeclampsia. So the clinical case is compatible, and absolutely the fact that 10 days later, without any treatment, everything normalized is the proof that this was preeclampsia. And I would not consider that biopsy as a reason for doing anything more. Because in my opinion, that biopsy was, as it happens, it's not, it happens in, especially when the biopsy is taken in a very complex situation, like in pregnancy or immediately thereafter, that biopsy does not give any sure information. So in my opinion, it was a very severe preeclampsia. This young woman will have to be followed up. And if she has another hypertensive, another pregnancy, she has to be followed up as a high-risk pregnancy with aspirin, strict follow-up, because she is at high risk of recurrent preeclampsia. But let me just say that there is one feature of preeclampsia that is often forgotten in the old definitions. Preeclampsia was a disease that had to go into remission within one month. And this last element was the most important one to define if it was preeclampsia or another disease. I'm not saying that you were not right in making a biopsy immediately, because this case had mixed features. And so if you had a collapsing glomerulopathy, a minimal change, a membranous nephropathy, you should have probably started the treatment rapidly. So it was a very good choice. But in my opinion, this biopsy is compatible with severe preeclampsia. And the story is the story of severe preeclampsia. Remission in 10 days, there is no other disease. And the fact that you have the podocytes are retracted is something that is seen at a higher or lesser extent in all severely proteinuric situations. There is a slight possibility that this was a strange case of like minimal change disease that can go into very rapid remission actually can have achy eye when the circulating volume is pretty much reduced. But looking at the probability, having hypertension is very, very severe hypertension is not a feature of minimal change disease with severe proteinuria and contracted volumes, because these patients are usually hypotensive. And she was highly hypertensive, which is a feature of preeclampsia. We usually say that there are only two diseases that go into rapid remission with heavy proteinuria, minimal change disease, and preeclampsia. Hypertension is not a feature of minimal change disease, it's a feature of preeclampsia. So clinically, this is a particularly severe case of preeclampsia. But she should be followed up in the long term. This is, at least, this is what I may be right or wrong, but this is what I would do.
Now, I think we have an important teaching point here that preeclampsia may present with nephrotic syndrome. Preeclampsia does not only present with subnephrotic range of proteinuria, it can present with whole picture of nephrotic syndrome. This is common. Yes?
This is not common, but this is a part. I mean, we usually, the term nephrotic syndrome is not used in preeclampsia for several reasons, including the fact that normal albumin level is about 30 in pregnancy. So such a lower albumin level is almost borderline with a classic diagnosis of nephrotic syndrome. So this is why usually preeclampsia is not labeled as nephrotic, but low albumin levels are not unusual. And sometimes, and sometimes they can be exacerbated by the fact that women are volume expanded and have lower albumin levels because of that. What strikes me is not the fact that creatinine normalized and proteinuria normalized, but it's the speed at which serum albumin normalized. So I suppose was the patient very edematous, and how much weight did she lose in the first 10 days after delivery? If you know.
Our patient wasn't edematous. She had mild lordopathy, not severe. She had mild lordopathy after delivery.
And how much weight did she lose from delivery to 10 days? Sorry.
Till we get there, I think we have a comment or maybe a question from Prof. Ahmed Adam.
Dr. Ahmed Adam.
Yeah, thank you very much. And actually, welcome to Professor Georgina. I saw her in our ESNT meeting this year. If you allow me, I got a few comments on the case and 2 questions to get the expertise of Professor Georgina about pregnancy with kidney anyway. Primarily, I will ask Dr. William, we do not have any medical history documented or any lab result of this young 19 years old lady. Am I correct?
Yes, no.
Right. I'm asking this question because, not for the question, because if she got a creatinine, for example, 0.8 and the up to 1.3 post delivery, this will change the diagnosis to become AKI, and I will support doing a biopsy. Otherwise, I'm not with this rapid action of doing biopsy. Maybe I'm incorrect, because it is not edematous. It is only got 20 gram proteinuria, which is a discrepancy with the albumin creatinine ratio only 7, which can occur, but must take in consideration. Doing a biopsy in 3-5 days postpartum, just as Professor Georgina, I will repeat, just for this very aggressive proteinuria, I will not do it. I did a biopsy in pregnancy, but for different other reasons. The second thing about the biopsy itself, although I will repeat what I've already said, that one glomerulus does not mean anything. The double contour may be artifact. The podocytes may be repeat because of the proteinuria. But the question about the diagnosis of chronic TMA, which definitely not correct to me because it recovered in 10 days. So definitely it is not chronic. So the biopsy will not help much in this case. So I will support the diagnosis of the preeclampsia with an odd presentation of a severe nephrotic syndrome. The very odd in this case, it is not edematous, despite 1.7 serum albumin, which is a very rare, although it happened. So this is my comment of the case, but I have 2 questions if Professor Georgina allow me and Dr. Rasha. Can I ask the questions?
Sure, you're welcome.
All right. The first question, do we have really a primary TMA? I'm asking this question because most of the pathologists said TMA because, and it is actually must be secondary. I asked a lot of US pathologists, and only one supporting the diagnosis that TMA may be a primary, but actually it must, by default, must be secondary. So what is the Professor Georgina about the implication? Do we have a primary TMA? This is the first question.
Well, I thank you. I mean, I fully agree with you. When you have let me just go back to one thing and answer to the question on TMA. AKI is now considered a part of a diagnosis of preeclampsia. So no wonder if in severe or in severe preeclampsia, you also have a reduction in the kidney function. This is not a criterion for excluding preeclampsia. It's a criterion for severity. TMA, well, you know, the diagnosis of TMA is so multifaceted because clinically and biochemically, you have all the spectrum from those that are characterized by a lot of things in the blood and nothing in the kidney to everything in the kidney and nothing in the blood. But HELP syndrome, if you consider that fantastic paper that was published and managed by Fadi Fakouri in 2020, I think, TMA and pregnancy, HELP syndrome is a form of TMA. So having TMA features in is compatible with having preeclampsia. So should we make all the battery of possible tests in this case? I would say no, because the resolution is a proof that it's no other disease than preeclampsia resolves so fast.
I totally agree, but just to emphasize, I didn't mention that the creatinine rising is a part of preeclampsia. I measure it as a supportive evidence for me to do a biopsy.
But I personally, let me say, if I was in my center in France, everything is reimbursed, patients can be hospitalized, there is no time constraint, I would have probably waited for a few days, 1 week to see what happened. If this unlucky young lady would have been, for example, in the hands of one of my best colleagues that Russia recently met, that is Alejandro Orozco, who is in charge of the nephrology team in the only dedicated hospital in Mexico City that makes 20 million inhabitants, hospital just for high-risk pregnancies, and in which the problem is that these women run away as soon as possible. She would have done a biopsy very early, and she would have done it with my full support, because sometimes when you are working in a very complex situation in which access to care is not the easiest, even if I'm absolutely admirative of the Egyptian system of health, especially for kidney care in pregnancy. But in these cases, you have to be fast, because then if a young lady runs away, you don't get her anymore. So there were at least two things that could evocate a kidney disease. One is the normal baby growth, and the other aspect of concern was the increase in serum creatinine. So we would have probably waited a little bit more, but we are in a different system, and some of the best experts I know would have done it very fast, and possibly also in some settings in the United States in which, as you know, care is not reimbursed, and you're reimbursed in a very short window after pregnancy. They would have done the biopsy not to lose the opportunity of diagnosing something else. The story says that it's just preeclampsia is never just, that it's things are probably explainable with preeclampsia, But I think that the biopsy was probably justified because this biopsy, I mean, we know it's not that, but not all the time. You have the time to wait a couple of weeks to start treatment, not to lose the patients, etc. So, and so I would say I would have biopsied her later, but I think it was fully justified to do it when it was done. There were reasons to do it. I would not do anything else now because it's a full resolution, but I would really brainwash her to be followed up from the beginning in next pregnancy, because I think this young lady has a very high risk of recurrent preeclampsia. Would she get pregnant again? And she's young, and she would probably like to be pregnant again. Your questions are perfect. I would start with aspirin, absolutely. Since the first positive test, I will follow her at least monthly during the next pregnancy or pregnancies. The biopsy, good decision. In the context, I think it's really a balance, and it depends upon the situation. Safe antihypertensive medication to breastfeed, first of all, ACI inhibitors. They are absolutely safe. But I suppose that this patient, the blood pressure went down rapidly.
Can I comment, please?
Yeah, sure.
Can I speak? Yes. Although the biopsy helped us to discuss with Professor Georgina, actually this is a good sign of the biopsy. Although I am agree with Professor Georgina, I will not do a biopsy, but I will follow the patient postpartum. If the creatinine going down, the blood pressure control, the patient is not edematous, there is no rush to do a biopsy. I will just mention one thing not to do a biopsy. If there is no great indication, even 1 in a million, this patient may be suffering from bleeding with her condition, which make scenario is not worse. But to answer what the biopsy a good decision, it is center directed, I can say. Can I ask the second question, and I will finish? Professor Georgina, how much did you do a kidney biopsy during pregnancy? And what is the indication? I'm asking this question because I did personally by myself only one biopsy in, I think, the 7th or the 5th month in an intensive care, and I diagnosed a rapidly progressive GN, and this is a scenario of AKI, and the patient actually received immunosuppression and helped her to be in a good shape after that. But I am asking about the expertise, how many you did a kidney biopsy during pregnancy and the indication?
Well, in the last 5 years, we did only one biopsy during pregnancy. But I think this case is a case in which we diagnosed PLA2R negative membranous nephropathy in a young lady of Indian origin that came to our attention at 10 weeks of pregnancy with 7 grams of proteinuria on 24-hour urine collection. So she got a biopsy, but PLA2R was negative. The proteinuria was mixed, not just albumin, and she and she was treated, and she delivered at 40 weeks of pregnancy, an healthy little baby girl of 2.8 kilograms. But and even when I was in Italy, out of more than 1,000 pregnancies that we have followed up, we had very, very few, I think less than 5 biopsies during pregnancy. But this was for 3 reasons. First of all, nephrologists were scared to take a kidney biopsy during pregnancy. And only now there is a better expertise about these. Most of the cases were referred in late pregnancy, in which the risk of bleeding were higher, and we were seeing the end of pregnancy arriving, so it was contextualized. And in the very last years, what changed was the availability of PLA2R and a reappraisal of the value of proteinuria selectivity even during pregnancy. So in the first weeks, if the proteinuria is non-selective and PLA2R are negative, I think it's wise to make a biopsy. And this is what we have done, but these are exceptional cases. Low-grade proteinuria, the beginning of pregnancy, low-grade proteinuria, we usually do not make a kidney biopsy. We put the patient on a diet with strictly controlled blood pressure, and we tend to follow them with the idea that in any case we would not treat a proteinuria of 1.5 grams out of the context of pregnancy with fully normal kidney function and no data suggestive, for example, of lupus or of another disease. But I mean, one of the things that make a difference is really the availability, especially of PLA2R. We were discussing, when Russia came and see us recently, we discussed 3 cases in which we made the diagnosis of membranous nephropathy in pregnancy. They were all treated in pregnancy, but 2 were PLA2R positive, so we did not need to make a biopsy. Would we not have PLA2R, we would have made a biopsy for a nephrotic syndrome before, I would say, 24 weeks. Or, as you were saying, in cases with rapidly progressive kidney function impairment, in which the young woman wants to absolutely to continue the pregnancy. Because in these cases, you have to know what you're dealing with, unless you have a lupus and you can blindly treat them. Maybe we are still too concerned on the risks, and once again, we learned a lot from the Mexican series, because up to now in Mexico, different with Egypt, women are covered for health care during pregnancies and just 1 month thereafter. So they rush to make the biopsy, because if they lose the opportunity of diagnosis, they have no other chance to give the right care to these women. We in Europe are generally much more cautious, but it depends also, as I said, upon the alternative options that you have. And another thing that I think is very important, would be very important to have, especially after 20 gestational weeks, is the availability of S-FLT1 PLGF, because they are not the Bible, not even the Quran, but they are very, very useful in ruling out preeclampsia. If the ratio is normal, it's not preeclampsia. If the ratio is very high, you have a diagnosis of preeclampsia or superimposed preeclampsia coming first. And this helps a lot to select the cases that have a nephrotic syndrome after 20 gestational weeks.
Thank you so much. I have a question for Dr. Wiam. This is patient to conceive spontaneously, or was the pregnancy or the conception assisted by assisted reproductive technologies, in vitro fertilization, or something like this?
A spontaneous pregnancy.
Yeah, I'm asking it because we have a series maybe presenting with severe or let's say typical preeclampsia after IVF, and we had a similar case like the case you are presenting now for a young woman, primary gravida, presenting around 20th week with nephrotic proteinuria and a picture of nephrotic syndrome. She had hypertension and a daily protein excretion of around 15 grams. And fortunately, we had the opportunity to send her labs to France, where the SFLT placental growth factor was performed, and so the anti-PLAR was performed here too and was found to be negative. And as Professor Piccoli just said, the SFLT placental growth factor has been very useful in diagnosis and prediction of preeclampsia. And SFLT placental growth factor ratio exceeding 85 has been considered diagnostic of preeclampsia. So for the patient I'm talking about, she had an SFLT placental growth factor ratio more than 500,000. So it was extremely elevated. And the patient had intrauterine fetal death within a few hours later. And after the termination of pregnancy, the patient had complete resolution of hypertension, proteinuria, and all abnormalities. One thing was diagnosis of preeclampsia. Professor Piccoli, you may recall the case if you would like to comment.
Oh, well, it's still in my nightmare for two reasons. The first one, that I went to France with the tubes with the samples in my pockets of my jeans. So I just, when I passed the control in the airport, I thought maybe I will remain for a long time in Egypt because it was too complicated to have all the papers to be able to get the samples. This is just for the heroic story. But when I left them to my lab, my colleagues called me immediately saying, this is the highest ratio S-split PLGF we have ever seen in our life. So this woman had two things that were highly suggestive of a kidney disease. The first one was that the onset was very early. And following this case, Rasha gathered, and I had the honor of working with her for putting the series together to write down the first ever published series of very early onset of a disease that has everything in common with preeclampsia, but does not comply with the definition of preeclampsia because it's very early, much before the first 20 gestational weeks, or the gestational weeks in women that had often several attempts of assisted fertilization. And then the other thing that was very troubling with this case was the fact that apparently the fetal growth was normal, but it was very early, so it's very difficult. I mean, the fetal growth changes are more evident after 20 gestational weeks. And since we had discussed this case before, when she was still pregnant, I still regret because if you have everything suggesting it's preeclampsia, the best thing that you probably have to do for the mother is to say, stop it. But she went forth, this young woman was exposed to the hormonal storm for at least 3 weeks until the story ended by itself. So this was starting from that. The problem, sending samples to France or to another place, is that it takes time. But if ever you have the possibility and such cases, and you can send us somehow the samples, we will manage doing the test very quickly. And it's very, very, very important, because it can avoid a kidney biopsy, but it can also guide what to do. I remember very well that case. And let me say one thing that I did not mention is that what we know about the definition of preeclampsia is in spontaneous singleton pregnancies, multiple pregnancies, and pregnancies obtained by assisted fertilization can have very atypical presentation, very early and very aggressive. But in this case, this was not the case, because the young lady conceived spontaneously, right?
Yeah. Thank you. Let us see if we have any questions from the audience. Anyone wants to comment?
Rasha, I have a comment about what is the indication of termination of pregnancy regarding proteinuria. And if our patient developed proteinuria in fifth month or 6th month, what about the implication of termination of pregnancy?
Thank you, Dr. Ahmed, for the question, and I'm gonna ask this to Professor Buckley once again, because there is two maybe not that correct concept. Number one is that preeclampsia does not present with nephrotic syndrome. This is one, and the second one is that proteinuria during pregnancy or nephrotic syndrome during pregnancy or kidney disease during pregnancy is an indication for termination. So how do you see this?
Well, I fully agree. This is a very good question. Let's say everything depends upon your neonatologist. If you have fantastic neonatologist, you can dare more, let's say, interrupting the pregnancies or inducing delivery. If you do not have a very strong support, of course you try to go longer. But to me, there are two indications for early delivery. One is uncorrectable hypertension, and she has 180/110, if I remember well, I suppose, with all possible treatments. So this is very scary, because the brain is of a woman with a pregnant woman is much more sensitive to damage, to press, and other situations like that than out of pregnancy. So very, very high uncorrectable blood pressure is a maternal indication. Increase in serum creatinine is a minor maternal indication, but after 34 weeks, in which usually the baby is viable, you risk more keeping the baby in the womb of a mother with severe hypertension, with all the risks, including placental abruption, than having her delivery. At 28 weeks, it's very different. and is very context sensitive. But and the other thing that apparently was not present in this case, but is an absolute indication to delivery, is when fetoplacental Dopplers are highly impaired, especially if there is an inversion of a flow, because you risk to have cerebral damage in the fetus, and probably is better to be out of a womb than inside of a womb in these conditions. But as I say, there is no absolute indication, because what makes the difference is not the nephrologist, is not the obstetrician, is the neonatologist. Where neonatology is very strong, you can prefer to terminate at 28 weeks in the face of a difficult maternal situation and with some initial Doppler alteration, and you have some Doppler alteration. When you have such a picture, you have some placental alteration, but they are not always very easy to detect. So in this case, I think they were absolutely right, not for the proteinuria, which is not a criterion per se, but because of the severe hypertension.
Yeah, so we agree on hypertension rather than proteinuria. Severely uncontrolled hypertension were not able to be ruled by all other measures.
Hypertension, you die. You do not die for proteinuria. Maybe you need to be anticoagulated, as very keenly one of the questions is about. But, and by the way, my answer, anticoagulant with hypoalbuminemia and post-cesarean section. In France and in Italy, heparin is given for 1 month after cesarean section to everybody. Maybe it's even too much, but it's never too little if you have hypoalbuminemia after delivery. Before delivery, if you decide to continue pregnancy, we usually use low dose, and an association between aspirin and heparin if albumin is lower than 2 grams per deciliter. But there is no guideline about this. Everybody does his own way and his own source. But hypertension scares me in pregnancy. I saw too many vascular problems with long-standing problems for the mothers. It scares me much more than high-grade proteinuria.
Yeah, it's interesting to know that every woman receives anticoagulation for 1 month after cesarean section in Italy and France.
I don't know if it's I don't know if it's right, but this is in France it's 1 month. In Italy depends, but it's usually at least one week until they start moving normally for prevention of deep venous thrombosis. I'm not for one size fits all, but these are the different practices, and it's not the nephrologist, it's the obstetrician that prescribes it.
Yeah, I think we ran out by the time. I'd like to thank you so much, Professor Prickly, for your precious time. Thank you so much. I'd like to thank Dr. Wiem and Dr. Ahmed and the team of Shebin ElKom Teaching Hospital for inviting us to this meeting. Dr. Ahmed, would you like to close?
Thank you, Dr. Rasha. Thank you, Professor Dr. Georgina. Thank you, Dr. Wiem, Dr. Ahmed Adam. We are happy to meet you. Thank you.
Oh, thank you. Thank you for involving me in this fantastic discussion. It's always a pleasure to, I'm the first one to learn from this kind of discussions. So thank you very much. And we start the weekend. I know that we have a little bit of difference in holidays, but have a nice end of the week. And I'm always happy to be involved if ever I can be of just a little bit of help. Thank you.
Thank you so much.
Thank you.
Thank you, everybody. Goodbye.
Thank you. Thank you. Good.